Thank you so much for allowing me to present this case among young cardiologists. I think I'm the oldest here. Before I start, I just would like to have a comment that when I teach fellows to do coronary angiography, I always support them till I feel they are ready to be on their own and do their angio without supervision. But I always advise them that whenever they have any concern about the finding of coronary angiography, they should consult with the senior before the patient leaves the cath lab. We don't want the patient to have a section or any problem and then it would be seen later on. It should be seen immediately by the senior. There's nothing wrong, even if the patient is stable. It's not wrong to have an experienced eye to look at and make a decision with you. We all have sometimes the days that is not our days, the day that is very busy or everything does not go the right way. The case I'm going to show you today is one of these examples. That was a busy day. I had busy schedule in the cath lab, and I was called by a colleague from another city referring a 57-year-old lady who is non-STEMI in the inferior wall. Angiography was done there, which revealed 2 vessel disease, heavy calcified proximal mid-LAD and RCA. The LAD was stented there, as you can see in the angio. Multiple stents were put there, but they could not cross the right coronary. They could not fix it, so they sent the patient for rotation angioplasty into our center. The patient came to the ambulance, and they had to accommodate this patient among my heavy schedule. She was diabetic on insulin, hypertensive, dyslipidemic with morbid obesity. Her weight was 124 kilogram, and her height is only 147 centimeters, very short and very obese. You can see this is the right coronary artery, and you can see probably the stent in the LAD here, you can see, but I didn't see the stent or comment on the stent in the LAD, which was put in calcified lesion. But you can see that the right coronary artery is heavily calcified, and there's a proximal lesion here. So we tried to do an IVUS to assess the calcification here, but it was impossible to cross with the IVUS probe. But whatever we were able to see, there was 360 degrees of calcium in the very proximal part of the right coronaries. With the help of a fine cross microcatheter, I was able to push, the rota floppy wire, and I did the first rota ablation with 1.5 millimeter rota burr. Usually I start with 1.25, but because of some financial issue of this patient, I went with 1.5. I hope that I can finish the case with 1 burr only. After the first run, the patient went into heart block, and I had to put a temporary pacemaker. You can see here the rota for the pacemaker, and here the rota after I put the pacemaker. I tried to, ablate this calcified lesion first. If you look here in this view, you realize that, I didn't have good backup support from the guiding catheter. See that the burr is not moving, and it's because of the calcification from one side, and the guiding catheter was not supported from the other side. After the first run, that's what I have seen. The wire is outside the artery. The distal part of the wire is hanging there, and there's perforation. Most likely is communicating with one of the right-sided chambers. So suddenly I have 2 problems here. I have broken wire in the distal part of the vessel, and I have perforation of the proximal part of the right coronary artery. Fortunately, the patient was stable. It does not have any significant hemodynamic compromise. So with the use of scion-blue wire as a body wire, I was able to cross the region again, and with upgrading balloon, I was able to dilate this area, which was ablated partially by the rotablator. And you can see here, this is just I dilated the vessel from distal up there. I tried to pass the stent at this stage, by support of a guideliner, but it was impossible because of the poor guiding catheter. So at this moment, and only at this moment, I decided to change the guiding catheter from Judkin right to Empress left. And that was a very important step, I was able to go with again, this time I used the bigger balloon, 3.5, and I dilated, I can see that the balloon is well opened in all the lesions here. I tried to retrieve the broken wire different times, and maybe we can have some advice here, what else we could have done, but it was not possible and time was passing, so I decided not to try anymore. And then I decided to stent the vessel from the distal part, jailing that broken wire with a stent and stent back to the ostium of the right coronary artery. So I put 3 stents in a row, 3.0 by 26 distally, and then 3.5 by 20. Then I wanted to use a cover stent to seal the perforation. Again, it was not my day, so I tried to pass a graft stent, but it did not go. There was a lot of resistance, and it dislodged and embolized. I will see now I was able to retrieve it back to the guide catheter, and then I removed it outside. And then I tried another one, smaller in size, and it dislodged again. But I was able this time to go with a smaller balloon and deploy it gradually by 1.5, then 2, then 3, then eventually I post-dilated all the stents in the right coronary artery with a 3.5 non-compliant balloon. This is, you can see that this is the dislodged graft stent, inflated the stent inside the guiding catheter, and I took it out. And then I went back and I started to stent from distally, mid-segment, and so on, till I reached the proximal part of the artery. And here you can see the final result. So the artery was opened nicely. I just left a memory there, this piece of wire, and the patient was stable and did very well post the procedure. She was discharged in stable condition. I followed her for about a year and a half. After that, she did very well on optimal medical treatment with lifestyle modification. So to conclude here, I think the lessons I learned from this procedure is to choose the right guiding catheter from the beginning. I think if I used the right guiding catheter, maybe I could have avoided all this, because you need to have better support, especially in this tough, calcified lesions. Retrospectively, maybe it would have been better to use a smaller burr and go gradually, not to cut corners and try to save, sometimes when you try to economize, you run problems. So maybe this is another thing that I should have stick to my strategy by using a smaller burr and then go up, so I can make life easier. However, calcified lesions are the enemy of the interventional cardiologist. They remain very high risk, challenging procedures, whatever experience you have. Thank you so much.